Andronic Ovasapian, great leader, teacher, mentor, friend. Many of us knew Andy Ovasapian later in his life. I didn't know much about his early life. Andy was born in 1936 in Iraq, Iran, and achieved his MD degree in Shiraz in 1961. In 1963, he came to the United States for an anesthesia residency at University of Pennsylvania, and in 1968 returned to Shiraz, and soon after that became the chairman of anesthesia at the university. In 1974, he returned to the United States, to Northwestern University. In 1983, he achieved the rank of professor, and in 1998, finished his career at University of Chicago. But of course, Andy was so much more than just an academic and a clinician. He was a fantastic leader and friend and thinker in the area of airway management and taught us all so much. He had a wonderful family. He enjoyed life. He was fun to be around. He was an enjoyable person to have leading us at the Society for Airway Management. As I prepared this tribute, I filed through many photographs that always showed Andy in a group of smiling people. He made friends wherever he went. They respected him. They loved him. I chose this particular photograph because it represented something that Andy loved in the end of his career, and that is the Society for Airway Management. This picture is of past presidents of the Society. I'd be amiss if I didn't include Dr. Richard Agababian. Richard was an emergency medicine physician, president of the Society, and unfortunately we lost Richard just a couple of weeks ago. The other thing I wanted to mention was the next meeting of the Society, which will be unique. It'll be at the World Airway Management Meeting. This will be a combined meeting of both the Society for Airway Management and the Difficult Airway Society of the UK. It'll be held in Dublin next November, and we hope that we'll see you all there. You can get more information at www.wam2015.com. Again, this is the Andy that most of us came to know, respect, and love, and I'm happy that I had a chance to learn more about the early years of Andronic Ovasapian. First, I want to say thank you to the Board of Directors of the Society for Airway Management for asking me to deliver the inaugural Ovassapian Lecture at the American Society of Anesthesiologists. It's a tremendous honor to be asked to address this group in the name of Andy Ovasapian. What I want to talk to you about today is something called the Airway Approach Algorithm, which is what I've been teaching for several years in regards to how we look at a patient's airway before we ever bring the patient to the operating room. We're all familiar with the ASA's difficult airway algorithm. It's really become a benchmark for the management of the difficult airway in the operating room, in other parts of the hospital, in other parts of the healthcare system, and everywhere in the world and in many specialties. Different specialties, different national organizations have their own algorithms, but they all refer back, they all cite the American Society of Anesthesiologists difficult airway algorithm. But I actually have two problems with this algorithm. First, any good algorithm starts with a root point and then goes on with a decision tree that leads you to action points. But the ASA algorithm doesn't start with a single root point. It actually has two root points. First, let's look at root point or root node B. This is the perceived routine airway. That is, patients who we evaluate as having routine or manageable airways will go into box B. Other patients, either with a known difficult airway or perceived to have a difficult airway, go into root node A. So if we consider patients with a manageable airway are in B and patients with a perceived difficult airway are in A, what we're considering is all patients. So all patients we take care of will pass through some part of the ASA's difficult airway algorithm. I think the difficult airway algorithm is misnamed. I think it should be called the all airway algorithm because all our patients have to pass through it. Now, the American Society of Anesthesiologists Difficult Airway Task Force does give us some guidance as to whether we decide that we should go into box A or box B of the algorithm. They ask us to assess the likelihood and clinical impact of basic problems, actively pursue opportunities to deliver supplemental oxygen, and consider the relative merits and feasibility of management choices. And the first management choice that they ask us to consider is awake intubation versus intubation after induction of anesthesia. And in fact, that's exactly how they divide the graphic algorithm. Box A is awake intubation. Box B is intubation after the induction of anesthesia. The goal of choosing the correct box is to stay away from the emergency pathway of the ASA difficult airway algorithm. But how do we make this choice? I think it's the most important preoperative choice we can make regarding the airway. Now, a few years ago, I was asked to consider this for the website Up to Date. I was asked to look at how we choose the induction or keeping the patient awake in a patient who might have a difficult airway. And I thought, well, I have to consider the patient who might have difficulty with mass ventilation without an aspiration risk, and that same patient with an aspiration risk, the patient with difficulty with laryngoscopy with no aspiration risk or with an aspiration risk, the patient who might be difficult with mass ventilation and laryngoscopy with no aspiration risk and an aspiration risk, the patient who might be a difficult supraglottic airway placement, and the patient who might be a difficult surgical airway access. I started working on this project, and pretty soon I had about 5,000 words written, then 10,000, then 15,000. The editor of Up to Date came back to me and he said, Will, we're only looking for about 2,500 words. I was a little put out by this, but the editor was nice and said, listen, we can help you, we can cut it for you. And I said, okay, thank you, that would be a big help, though I wasn't quite happy about the situation. The editor then said, by the way, why is this topic so confusing? I mean, after all, the ASA difficult algorithm is pretty straightforward. And I thought, the editor's right. The ASA algorithm is straightforward, especially if you reduce it down to its skeleton. It's really very simple pathways. The ASA algorithm, the algorithm of the Canadian Airway Focus Group, the Italian Society, the German Society, the DAS algorithm, and algorithms by individuals. You might be familiar with the vortex concept are simple algorithms very often, but they deal with the intraoperative course. They deal with the patient who is potentially difficult or the patient who we consider not to be or perceive not to be difficult. But how do we make that decision? Do these algorithms help us with choosing box A or box B, for example? Now, the Canadian Airway Focus Group does give us some guidance. They ask us to consider things like risk of aspiration, how fast will this patient have oxyhemoglobin desaturation if we can't control the airway. But they don't give us an algorithmic approach to looking at those problems. There was a paper or a letter that was introduced to me several years ago by my colleague Jeffrey Schwartz. This is by Tanaka et al., the year 2000 in Anesthesia and Analgesia, and the title was, Is Awake Intubation Necessary if a Laryngeal Mask Airway is Feasible, if it'll work? And the Tanaka group had a very simple algorithm. They say, well, let's say we evaluate a patient, and the patient is found to be extremely difficult to intubate or ventilate on our evaluation. Well, we can go ahead and do an awake intubation. And let's say we evaluate a patient, and it's predicted that their airway will be easy to manage. Well, we can induce anesthesia and take care of that patient. But what about the patient with some but not extreme difficulty? In this case, we should go ahead and evaluate for the use of a laryngeal mask airway. The two endpoints that this algorithm got to are the same points of the root nodes of the ASA difficult airway algorithm, awake intubation versus intubation after the induction of anesthesia. Tanaka essentially made an algorithm for entering the ASA difficult airway algorithm. My thought was, can we take the Tanaka algorithm and expand it to include all the factors that the ASA Difficult Airway Task Force has asked us to consider? What would Andy say about this? Well, I had the chance to present the Tanaka idea to Andy, and Andy said, Vil, that's what he called me, Vil, everybody has their algorithm. Well, I thought about this, and I thought, how can I expand the Tanaka concept, given the items that the ASA asked me to consider? Well, I boiled it down to 5 questions, and I asked these 5 questions in choosing A or B for all patients I take care of. Question number 1, must the airway be managed? 2, could your laryngoscopy be at all difficult? 3, could supralaryngeal ventilation be used if needed? If you got into trouble, could you use supralaryngeal ventilation? 4, is the stomach empty? That is the patient an aspiration risk? And 5, will the patient tolerate an apneic period, or will the patient tolerate an error in judgment above and not immediately oxyhemoglobin desaturate, but give you a chance to correct the problem? If I answer no to any one of these questions, it leads me to a clinical path, either A or B of the difficult airway algorithm. And if I answer yes, it leads me further down into the Airway Approach Algorithm. Must the airway be managed? What are the factors? We have to consider the surgical procedure. Is this a procedure that requires airway management, or can it be done with a regional infiltrative anesthetic? How about the surgeon? What's the comfort of the surgeon with regional infiltrative anesthesia? This is Dr. Peter Schwartz. He's head of OB-GYN oncology at Yale. And if we say to Dr. Schwartz, I think this next case would be very appropriate for an epidural, what we're going to get is no. Dr. Schwartz does not like regional anesthesia. He's just not comfortable with it. Surgeon comfort. Of course, we have to ask the patient what they would prefer. Some patients would prefer general anesthetic. Some patients would prefer regional anesthetic. We should consult the patient. And then your judgment, your preference, your comfort. This is my friend Peter Adanasoff. You can see on his sash he's wearing a do not laryngoscopy sign. Peter would rather not use a general anesthetic. His tool of choice is the needle. He prefers regional anesthesia. That's his comfort zone. Why is that last on the list? Because it has to be the bottom line. And the first hallmark I'll make of a good clinician is that they're able to go to the surgeon, go to the patient when there's a disagreement in what choice is to be made, and they can explain why, on the condition of the patient, the reason for the surgery, and the comfort level of the anesthesiologist, one technique is better than another technique. If we answer this question no, we could potentially do a regional or infiltrative anesthetic. But the ASA makes clear that using local anesthetic infiltration or regional nerve block does not obviate the need for a pre-formulated strategy for intubation of the difficult airway patient. If we answer this question yes, we go on to the next question, which is, could your laryngoscopy be at all difficult? And you might consider this airway evaluation. I consider this risk assessment. What's the risk that my laryngoscopy and intubation will fail? And what is my tolerance for that risk? The factors involved can include the history of difficult airway management, airway surgery, trauma, or radiation in the past, incidental history. Did the patient have a broken tooth or a bad laceration on the last laryngoscopy or intubation that they had? Signs and symptoms of stridor, bleeding, dyspnea, pathological conditions, arthritic syndromes, cervical spine pathology and fracture, and how about airway pathology? We could have a patient coming to us with pharyngeal, hypopharyngeal, or laryngeal pathology, and we can examine their mouth, their chin, the range of motion of their neck, but in truth, this patient's airway is a black box to us. We don't know what's going on. This is akin to what K.B. Greenland called the middle column. Middle column, invisible to the naked eye, can be occupied by airway tumors, lingual tonsil hyperplasia, other pathology, which are commonly evaluated by the ear, nose, and throat specialists, Dr. Greenland highlights. Now, this is my otolaryngologist specialist. This is Dr. Clarence Sasaki. And I had a case just the other day where I was unsure what the pathology was in the airway, and I asked Dr. Sasaki, am I going to have any problem with this patient's airway?
Your airway is fine.
That was Dr. Sasaki's response. And it's funny, I had the same response from Dr. Sasaki when I asked him the question 9 years earlier.
The airway is fine.
I went back to Dr. Sasaki and I said, are you sure? I mean, I got the same answer from you today as I did 9 years ago. And he said,
the airway is still fine.
Dr. Greenland goes on, the ears, nose, and throat specialists may not be aware of the various devices and maneuvers used by the anesthetist. When the otolaryngologist looks at the airway, he examines for extent of disease, preservation of function, the immediacy to go to the operating room. The otolaryngologist is not examining for the ease or difficulty of managing that airway. What we're doing currently at my institution is preoperative endoscopic airway examination. And this is something that can happen in the preoperative clinic, the holding area, or in the operating room. In this case, this woman had a history
Chin up in the air.
radiation and surgery to her airway, and she presents with pharyngeal stenosis. And here we're doing a preoperative endoscopic airway exam, and we can see tremendous stenosis of her pharynx. Beyond this stenosis, we see the epiglottis, and now we see the vocal cords, and we'll get a little peek of her esophagus. The duration of this exam was about 1 minute and 37 seconds. We published a paper on this. Preoperative endoscopic airway evaluation provides superior airway information and may reduce the use of unnecessary awake intubation. I don't have to ask what would Andy say about this. I know exactly what Andy did say about this. He said, Vil, what's so wrong with a little awake intubation? Andy was a great proponent of awake intubation, and he felt it was an important skill that every anesthesiologist should master and keep practicing. And he was always ready to give some advice. For example, when performing awake intubation, the patient typically needs less midazolam than the anesthesiologist. In the study that we performed, there were 138 patients who presented for biopsy or surgery on an airway mass. After clinical exam and history, it was decided that 44 of these patients would go into box A of the difficult airway algorithm, that is, they'd be intubated awake. 94 patients would go into box B, airway management after the induction of anesthesia. We then did a preoperative endoscopic airway evaluation. After the evaluation, only 24 patients were going to have an awake intubation, and 114 patients, an increased number, were going to be in box B. But of course, the important information is in the details. After preoperative endoscopic airway evaluation, there were 28 patients that were originally slated to have an awake intubation who were found not to be very severe in their pathology, and they were managed with airway management after the induction of anesthesia. Much more importantly, there were 8 patients who, after clinical exam, we were planning to manage by routine means, who were found to have such significant disease that they were managed with awake intubation. This is one of those patients, patient with recurrent papillomas. This patient had presented to us many times, had always been managed in box B of the difficult airway algorithm. This time, he had recently had a tracheostomy, and he presented with essentially the same symptoms as he had always presented with, and after exam, it was decided that he be managed after the induction of anesthesia. But a PEAE was performed, and this is what we saw. This larynx was filled with papillomas. You can already see bleeding from minor trauma from the exam. This patient moved from box B to box A and then was managed in the operating room with awake intubation. How about our routine exams and interpretation of those exams? These are the routine exams that we're all used to, and we know from literature, like that by Dr. Shiga in 2005, that of these multiple tests, they have marginal to poor sensitivity and only modest specificity. Let's look at some of those numbers. If we look down at oropharyngeal grade, we see the sensitivity of the test can be 0.4 to 0.67. That is 40% to 67% sensitivity in picking up difficult airways. The specificity is a little bit better. We can also look at something called interclass coefficient. This is the ability of 2 clinicians to look at the same patient and agree on the score. If we look again at oropharyngeal grade, we see the oropharyngeal grade is about 50%. That means half the time clinicians looking at the same patient will agree with each other. That is, they probably agree with the person or the investigator studying the oropharyngeal grade only 50% of the time, and that investigator might agree with Dr. Rao Malanpati only 50% of the time. This is one reason these tests tend to be unreliable. Does it matter that these indices are poor predictors? In my opinion, no. I think they're useless unless they're near 100% sensitive and specific. Why do I think this way? It has to do with tolerance of risk. Dr. Stephen Yentis in Anesthesia 2002 dealt with this concept. He said, let's take a population of patients who a priori are easy to intubate, and a second population that a priori are difficult to intubate. Now let's develop our own test. Dr. Yentis developed a test called the Yeti test. I'm going to use the Iticus test. What's Iticus? I thought I could intubate score. It's my own personal test of if I think I can manage that patient with routine means. So let's say my Iticus test has a value from 0 to 10, and I choose a value as 5, which completely divides these two populations. The sensitivity is 100%, the specificity is 100%, and the positive predictive value is 100%. This is a fantastic test. But Dr. Yentis points out it's not that clear, because populations of patients who are easy to intubate, patients who are difficult to intubate, when you apply tests to them, there's actually overlap in the populations. He also points out that the populations are not equal. The population of patients that are easy to intubate vastly outnumbers the population of patients who are true difficult intubation. So you can see here our sensitivity is only 60% and our positive predictive value is pretty bad at 30% with an Iticus score of 5. We can raise our Iticus score, our cutoff, to 6, and here our positive predictive value has gone up to 50%, but our sensitivity has dropped way down to 20%. The problem here is that 80% of the time we'll get a false negative, and that patients who are difficult intubations will not be picked up by an IDICUS score of 6. We could use an IDICUS score of 4 as our cutoff. Here we have a sensitivity of 98%, but a positive predictive value of 20%. There's two problems here. Problem number one, there are still going to be individuals who are at risk of failed airway management. And problem two is a large number of false positives will occur, and this is going to influence my future risk tolerance. What would Andy say about this? He said the best thing about the Mallampati classification is that it makes the clinician look in the mouth. Now, I don't think that Dr. Ovasapian disrespected Dr. Mallampati. I think what Dr. Ovasapian was saying is that these scores are misused on patients and they're misinterpreted. And at least it forces us to examine the patients and make a decision. Instrumentation. How does this influence our decision about laryngoscopy and intubation? We live in an era of a cornucopia of intubation devices, and not all are going to be available to every practice. This is an interesting letter in the Canadian Journal by Dr. Wanderer and group, and what they did is track the number of uses of video laryngoscopy as they acquired more video laryngoscopes in their practice. And you can see as the number of video laryngoscopes went up, there, of course, the use went up also. This was video laryngoscope alone or video laryngoscope with a bougie. They also tracked the number of awake fiber optic intubations, which they consider their difficult airway population. And you can see the difficult airway population went down. Now, Dr. Calderoli et al. Asked the question in 2014 of the Wanderer group, did the introduction of video laryngoscopy reduce the number of difficult airways and the need for awake fiber optic intubation, or did it just reduce the perception that airways were difficult? That is, in truth, there may have been no decrease in the true difficult airways, but just the perception of difficult airways. And the Wanderer group agreed with this assessment. They said, our data is not good enough to tease out that question. Experience. What Andy said about experience is all experience is not created equal. And let's look at these two individuals to get an idea what he means by that. If I had a patient with a difficult airway, there's no one else I'd rather have by my side than Andronic Ovasapian, who we see here, really a master in taking care of the airways. The second individual here is Paul Barish. Now, if I had a patient who had cardiovascular disease, I would rather have Paul Barish by my side. These gentlemen had roughly the same amount of clinical experience, but yet the type of experience they had matters. What's our overall rate of difficulty with laryngoscopy? With the Macintosh blades, about 5.8% of the time we can expect a high Cormack-Lehane score. With the glide scope, 0.2 to 1%. With the McGrath, 2%. And the Storz VideoMac, 3%. How does experience affect these rates? This is a great study that just came out recently by John Sacklis. John Sacklis is an emergency medicine physician. What this group did is they looked at trends after they acquired their glide scopes in their practice from 2007 to 2014. In 2007, they were seeing an overall rate of Cormack-Lehane score of 1 and 2 in their practice of 95.6%. First pass success rate with a tracheal tube with the glide scope was 75.6%. By 2014, the rate of finding a good Cormack-Lehane score had not changed, but yet the rate of first pass success with intubation went up markedly. This is an example of institutional learning. As an institution, with new residents coming in and going out, new attendings coming from other institutions, people practicing with video laryngoscopy, their first pass success rate increased dramatically. Now, in data that was in press at the time this lecture is given, another study looked at individual learning curves. That is, as residents progress from PGY1 to PGY2 to PGY3 in their program, what was their individual learning curve with success with video laryngoscopy? And you can see that video laryngoscopy success, first pass placement of a tracheal tube, increased dramatically over the 3 years. What's very interesting about this study is that there was virtually no change in the success rate of direct laryngoscopy over the same time period. Can we do better than this? Can we determine if new technologies have patient-specific applications? That is, do clinical conditions matter, and can we develop pathology-specific devices? Now, Dr. K.B. Greenland discusses this in his Anesthesia editorial, 2014, Spinning Silk from Cocoons. And he said, by promoting structured research with clearly defined aims, he asked, can new devices be matched to particular difficult airways? I think Dr. Green would like this study. This is a study by Dr. Bradley Hinman in the Michael Todd group, Anesthesiology 2014. It compared the direct laryngoscope with the AirTrack device. It measured changes in cervical spine, motion, and applied force. And this group found a different center of force with the Macintosh versus the AirTrack. That is, the center of force being more distal with the Macintosh. 4/5 less force was applied with the AirTrack device, and there was 1/3 less cervical motion with the AirTrack device. Going back to Dr. Greenland's editorial, he interprets Yentis in saying that difficulty with the airway is subjective and may be influenced by device availability, the skill and experience of the operator, and the environment in which they are operating. I dare to add to this risk tolerance, especially at the moment. For example, I could have 364 good days in the operating room where everything goes well, and then one bad Friday where that one patient not picked up by my personal ITICA score fails airway management. When I come back on Monday, I'm going to have a new tolerance. I'm going to use a new level of ITICA score to make sure I capture all my difficult airways. So question number 2, we use availability of devices, perceived difficulty, my experience, and my risk tolerance. And I might answer the question, no, I don't expect any difficulty with this airway. And I make sure I do this using most sensitive value that I feel comfortable with my personal ITICA score, to make sure I've eliminated all the difficult intubations. I'm confident that laryngoscopy will be straightforward, and I'm going to proceed as clinically appropriate. That is, I'm going to enter box B of the difficult airway algorithm. It's the everything appears okay box. And a prototypical case is rapid sequence intubation. But what if laryngoscopy fails? What if I have this one patient who turns out to be left of my cutoff on the ITICA scale? What would Andy say? Well, Andy would say it's lingual tonsil hyperplasia. It's lymphoid tissue at the base of the tongue which causes unexpected failed laryngoscopy. And this was from his 2002 paper with Glassenberg, Randall, Klock, Mesnick, and Klafta. This patient is now in box B of the difficult airway algorithm. Laryngoscopy fails, and the beauty of the algorithm is it'll take this patient and lead this patient through either the non-emergent pathway or the emergent pathway in ways to salvage this airway. But what if, based on perceived difficulty, experience, availability, and risk tolerance, I'm sure of difficulty with laryngoscopy, or I'm unsure of difficulty? I'm going to call this patient a potential cannot intubate. I'm going to answer this question yes. And when faced with a cannot intubate, we generally ask, can we ventilate? And that's question number 3 of the Airway Approach Algorithm. Could supralaryngeal ventilation be used if needed? What's supralaryngeal ventilation? It's the face mask. It's the LMA. And nowadays we have many new devices which we use as supraglottic airways. The King LT, the Cook gas, the iGel, and about 23 or 4 more devices. As far as face mask ventilation, in the year 2000, Landron produced this paper where he showed 5 independent predictors of difficult mask ventilation: age greater than 56, BMI greater than 30, the presence of facial hair, the patient who's edentulous, and the patient who snores. And in his big data studies of 2006 and 2014, Kurpetal et al. Also identified a Malampati 3 or 4, a history of radiation therapy, and male gender as being additional factors predictive of difficult mask ventilation. But what about the intangible factors? What about the cues, the exposure that the clinicians had in the past, the experience of the clinician? How do these figure in to the decision regarding mask ventilation? Here's a case that presented to our preoperative clinic. The patient has a large parotid mass that extends into 2/3 of the pharynx. The clinician evaluating this patient felt the patient needed an awake intubation, as did the surgeon and several other clinicians that saw the patient. But the anesthesiologist who took care of the patient felt differently. After looking at the patient's face, the expression when deep breathing, listening to the breath sounds, this clinician felt that it was safe to do an inhalation induction. Here we see the patient in the operating room, pre-oxygenated. The patient feels breathing. The gas is now on. The patient is self-releasing. To the point where the patient can now be mask ventilated. IV muscle relaxants are given, and the patient will now be intubated with a flexible fiber scope. We can obviously see this mass occluding the pharynx and pushing down into the hypopharynx, and the patient is now being intubated with a fiber scope. What was it about the cues, the intangibles that this clinician saw that let them go ahead with inhalation induction and mask ventilation? Something that experience and exposure only gives one, and it's something that I think is going to have a hard time being modeled. When it comes to supraglottic airways, this study of 16,000 patients by Dr. Ramachandran found male gender, high BMI, poor dentition, and table rotation around from the clinician being factors that may present with difficult supraglottic airway placement. This paper found a 1.1% failure rate requiring intubation. But what about unexplained failures? I think my failure rate's greater than 1.1%. Well, I won't ask what Andy would say in this case, but what would Archie say? I had the opportunity to ask Dr. Archie Brain. Here we see a picture of the young Dr. Archie Brain contemplating one of his first supraglottic models. Why do we have unexplained failures with supraglottic airways? And Dr. Brain's explanation was it has to do with operator technique. And I think if we ask Dr. Brain, Dr. Frost, Dr. Miller, Dr. Nasir, Dr. Cook, the inventors of the supraglottic airways, about their insertion techniques, we would find that their devices were designed based upon the specific insertion techniques, which become very important. And if you're having difficulty with supraglottic airways, look back at the original descriptions of these techniques. So to answer this question, the operator must rely on his or her personal experience, should probably not rely solely on the published success rates, and should have an out, a rescue technique, a salvage plan. And this will be question 5. What about a role for preoperative endoscopic airway evaluation for ventilation? Here's an interesting case that I recently had. This is a patient who presented with a diagnosis of epiglottic cyst. This is a preoperative endoscopic airway exam, and here we see this large cyst in the hypopharynx. And if we watch carefully, what we're going to see is that the cyst is sucked into the larynx with inspiration. So here the cyst is pulled into the larynx. We'll see this again. The cyst is pulled into the larynx with inspiration. This is a patient that maybe we could intubate by pushing that cyst to the side, but if we can intubate and we wind up having to ventilate this patient, it can be very difficult. If we answer this question no, how does this interface with the difficult airway algorithm of the ASA? Well, we've already said this patient could be a difficult laryngoscopy. We'll call this the cognitive equivalent of cannot intubate. And now we're saying the patient is the cognitive equivalent of cannot ventilate. Cannot ventilate, cannot intubate is the emergency pathway. We never want to be in the emergency pathway. So in this case, we're going to choose box A, awake intubation. Let's say we're confident that we can ventilate this patient. We're going to answer this question, yes. The next question is the stomach empty? That is there an aspiration risk? That's beyond the scope of the current discussion. It's going to depend upon the NPO status of the patient, the metabolic status of the patient. Do they have kidney disease? Have they been on opioids? Do they have GI disease? Are they coming out of the ICU? Are they cachectic? There are many factors at play here, so we're simply going to answer the question as no, and we've reached a point where we're at the cognitive equivalent of cannot intubate, and now the cognitive equivalent of should not ventilate. This also adds up to the emergency pathway. We never want to be in the emergency pathway. This patient will go into box A of the difficult airway algorithm. Let's say we feel this patient's not an aspiration risk. We answer this question yes. At this point, I should be able to proceed. I feel confident that if I can't intubate, I can ventilate this patient. But what if I'm wrong? And I think that's the second hallmark of a good clinician. Before giving a drug or doing a procedure, the clinician says, what if I make an error? Am I going to be able to rescue this patient before damage occurs? And I'm especially concerned about question number 3. Patients don't need to be intubated in most cases. They just need to be oxygenated and ventilated. So question 3 is key. I'm going to ask one final question. If I'm wrong about being able to ventilate, will the patient tolerate an apneic period? This is Dr. Cal Watsky. Cal's a friend of mine. He's a very healthy guy, about 58 years of age. He's a bicyclist. He's a hiker. He's in very good shape. We're going to look at healthy Cal. This is his brother, the smoker. This is smoker Cal. He smokes half a pack to a pack a day. He doesn't have severe lung disease, but he's got some changes in the lung. This is cachectic Cal. This is the patient who's wasted, comes from the ICU. He has an oxygen deficit. He's going to be very hard to pre-oxygenate. This is fat Cal. That's the morbidly obese or super morbidly obese patient. And the adult patient who's at the highest risk of oxyhemoglobin desaturation, pregnant Cal. So we're going to look at these 5 patients, and what we're going to do is take the twin of healthy Cal and pre-oxygenate that twin, and we're going to pre-oxygenate the other Cals. Now we make them apneic. What's going to happen? Well, healthy Cal, who has not been pre-oxygenated, is going to desaturate it in about 1.5 minutes. If he's pre-oxygenated, healthy Cal may last from 5 to up to 10 minutes before desaturating under 90. Smoker Cal will last 5 to 7.5 minutes. Not too bad. Cachectic Cal, who we have trouble pre-oxygenating, will desaturate in 2 to 4 minutes. Fat Cal, about 2.5 minutes. And the highest risk patient, pregnant Cal, in about 1.5 to 2 minutes. Some clinicians would say, well, I could use succinylcholine and let the patient start breathing again. But the data on this is questionable. A lot of clinicians have found different durations of apnea with succinylcholine and may not trust it to have the patients at higher risk come back breathing again. How about the sequestering drugs like Sugammadex, sequestering drugs like rocuronium? Once again, the literature on this is on both sides. There are some clinicians who feel that Sugammadex can reverse rocuronium block fast enough to prevent oxyhemoglobin desaturation, but there are several reports where Sugammadex did not work adequately. So I'm not going to trust the health of my patient and the well-being of my patient to that possibility quite yet. Will the patient tolerate an apneic period? If the answer is no, as we might answer with cachectic Cal, morbidly obese Cal, and pregnant Cal, I'm going to bring that patient through box A of the difficult airway algorithm, awake intubation. But I might decide to make an exception, and that is question 5B. In an emergency, can hypoxia be rapidly prevented or corrected by other means? And what I'm speaking of here is translaryngeal oxygenation, where we use high-pressure oxygen through a needle in the neck emergently to reoxygenate the patient. Now, not all patients will be eligible for this kind of rescue. For example, this patient has severe radiation changes to the neck. It's going to be very difficult to put a needle through her cricothyroid membrane. This man, morbidly obese, and this woman with severe kyphoscoliosis, it's going to be almost impossible to find the cricothyroid membrane. This gentleman has a fungating mass near his cricothyroid membrane. His surgeon is not going to be very happy if your rescue plan includes putting a needle in and around that cancerous lesion. It's also going to depend upon what equipment is available to us. Do we have high pressure oxygen, and do we have the equipment available immediately to do translaryngeal jet oxygenation? And it depends upon where we are, in the operating room, in the ICU, in the emergency department. Is there the facilities and the personnel to help us if we get into trouble? Will the patient tolerate an apneic period? If the answer is yes, I will go into box B of the difficult airway algorithm. So the Airway Approach Algorithm is a decision tree approach to enter into the ASA difficult airway algorithm, pulling in all the factors that the American Society of Anesthesiologists Task Force on the Difficult Airway asks us to consider when making this choice between box A and box B. What would Andy say about this? I don't know. I never had a chance to really discuss the Airway Approach Algorithm fully with Andy. I hope that Andy would appreciate that I took the lessons that I learned from him in developing this preoperative decision tree approach to entering into the ASA difficult airway algorithm. Thank you very much. I want to invite you to email me to receive the Airway Approach Algorithm card. This card has the algorithm imprinted on it and the entry into the ASA difficult airway algorithm. It also has my email address, and I invite you to comment on the concept of the Airway Approach Algorithm. Again, you can email me at will.rosenblatt@yale.edu to receive the card, and let me know if you'd like cards for your trainees or other members of your group. The reverse side of this card has my recipe for awake intubation. This is a summary of the refresher course that I present at the ASA. Please also feel free to check out our AirwayOnDemand YouTube channel, where you'll find a variety of videos on airway management.